Hello, everyone. My name is Dr. Casey Hewitt, and for the summer, Annie Reyes and I have enjoyed being your moderators. We are pleased that you could join us for this week's lecture from our first 7-week No Neuroanatomy mini-series that brought you lectures from experts in the field covering different neuroanatomy topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would also like to recognize our No Neuroanatomy planning group for their hard work pulling this mini-series off. We would also like to thank our sponsors for their financial support for the series. Now, before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left side of your screen, and a recording of today's lecture will be provided on our website later this week. Questions will be asked at the end and not during the lecture. Today's Q&A is led by Annie Reyes. Now it is my pleasure to introduce Dr. Ronald Lazar for today's lecture exploring neurovascular neuroanatomy. Dr. Lazar holds the Evelyn F. McKnight Chair and is Professor of Neurology and Neurobiology in the Department of Neurology at the University of Alabama at Birmingham, better known as UAB. He is also the director of the UAB McKnight Brain Institute and the director of Neuropsychology Division. A graduate from New York University with a prize in psychology and a PhD graduate in psychology from Northeastern University, he completed postdoctoral training at Georgetown University and the Eunice Shriver Center before being awarded an Andrew W. Fellowship to study the neuropsychology of cancer at the Memorial Sloan Kettering Cancer Center. After serving as assistant professor of neurology at SUNY Downstate Medical Center in New York, he became professor of neuropsychology and neurology and neurological surgery in the stroke service at Columbia University Medical Center and director of the Richard and Jenny Levine Cerebral Localization Laboratory at New York Neurological Institute. In June 2017, he began at UAB. Dr. Lazar has served as a chartered member of the NIH Studies Section and FDA Advisory Panel. He was editor-in-chief of Neuropsychology Review. The second edition of his book, Neurovascular Neuropsychology, was published by Springer in 2020. And presently, he directs the Neuropsychology Clinic and sees patients with cognitive disorders from cerebrovascular and cardiovascular disease. He is a fellow of the American Psychological Association, the American Heart Association, American Stroke Association, and the American Academy of Neurology.
Well, thank you for that kind introduction. Can you hear me?
Yes, we can.
Great. So I'm delighted to have the opportunity to talk about cerebral vasculature. It's a huge field, and I try to sort of bring it down to some core elements as we go along. There's still a lot of detail, and I'll try to keep some focus both on the anatomy as well as some of the clinical relevance of the things that I'll be talking about. So there are 400 miles of blood vessels in the human brain. And even though the brain only occupies about 2% of the total body mass, the brain uses about 20% of the blood supply. So it's not surprising that we have such a rich vasculature that goes into the brain. So I think that if we're going to talk about the vasculature, we have to start with the heart, which is over here. And this is kind of a cartoon. And of course, you have the aortic valve here and then the aortic arch coming down. So out of the aortic arch, you have generally 3 large great blood vessels. Now, I want to emphasize that this is common in most people. It's not the anatomy necessarily in all people. There are all kinds of variations that take place that functionally do the same thing. So this is sort of the classic look, but it does not occur in everybody. So the first great vessel here you have is the innominate or the brachiocephalic. The brachiocephalic goes up, and out of it comes the right internal carotid artery, which then separates or bifurcates into the internal carotid and the external carotid artery. I'll come back to those later. And then as we go more distally on the innominate, you have here coming out right vertebral artery that goes up here, which I'll talk about in a second. And then the right subclavian artery then goes and supplies other parts of the systemic circulation. The next great vessel as the blood goes along is this vessel here. And this is the left common internal carotid artery, which bifurcates into the internal and the external carotid artery. And then finally, the last great vessel is the left subclavian artery, which is here, out of which the left vertebral comes out along here. So the blood supply of the brain comes off these vessels and through the carotids and the vertebrals. So here is one of Frank Netter's pictures. Here is the aorta coming out. This is the left common carotid artery, no, rather the right common carotid artery bifurcates into the external, which supplies the eyes and facial area, and then the internal carotid, which then goes into the circle of Willis. Then back here, you have the vertebral artery that goes up the vertebral body, as you might think. And this is the right vertebral there. This is the left vertebral coming right up behind it that you can see here. It's adjacent to it. And then they merge together into the basal artery. And this is probably the only place in the human body where rather than a vessel splitting as we go more distally, here you have two vessels coming together to form the basilar, and it's very unusual to come into a single vessel. And this goes into the back part of the circle of Willis. So here we have another picture from Netter's collection here. Here's the circle of Willis that comes around here. The internal carotid comes into here. The internal carotid comes into here. And then this is the base of the brain, okay, right over here. And then you have the middle cerebral artery coming here on this side, and then you have the middle cerebral artery coming on this side. The temporal lobe here has been resected, if you will, so to get a better look at it. You can't normally see it if you look at the base of the brain. This is a normal temporal lobe, and you could see what happens is that the left middle cerebral artery actually goes between the temporal lobe and the base of the frontal lobe through the operculum and then comes out the side. Then at the back of the circle of Willis, this is the basilar artery that comes up here. And then it goes into this is the posterior communicating artery on this side, the posterior communicating artery on that side. And from here comes out the posterior cerebral artery coming out here, and the superior cerebral artery coming out here as well, okay, which feeds the occipital region. I'll talk about those in a moment. And then the circle of Willis goes anteriorly here, and this is the anterior communicating artery on this side, the anterior communicating on the other side. This is the optic chiasm over here. And then they come up here to the front of the brain, and you'll have the anterior cerebrals coming in the medial region. Circle of Willis, middle cerebral, anterior cerebral, posterior cerebral arteries, and that is what supplies the cerebral cortex. So here we have a sagittal view of the left side of the brain. They have retracted. This came out of a book that a chapter that Joanne Festa and I wrote a couple of years ago. So we've retracted the temporal lobe here so you can get a better look at the middle cerebral artery coming up. And at this point right over here, after it comes over the temporal lobe, it splits or bifurcates into two major divisions. This vessel here is the lower division of the middle cerebral artery, and it supplies the posterior parietal as well as the superior temporal. And as many people know, when you get an occlusion of the lower division of left middle cerebral, that's what typically gives you a Wernicke's aphasia. Then you have the other part of this bifurcation here, and this is the upper division of the left middle cerebral artery. And you can see that it kind of creates sort of a candelabra, and that's often referred to as the candelabra. And this applies as the lateral region of the left frontal lobe over here. when you go to vascular conference, which often includes neuroradiologists, they have a slightly different nomenclature. When they refer to this area here of the middle cerebral artery before it bifurcates, they often refer to that as M1. And this area distal to that up to here, they refer to as M2. And they have the same kind of 1, 2, 3, and 4 designation for the MCA, PCA, and the ACA as it gets more distal from the a circle of Willis. So you'll sometimes hear that referred to rather than other segments of the MCA, PCA, and the ACA. So this is a medial view of the right frontal lobe. Okay, here you have the anterior cerebral coming up, and you have the pericallosal here, and you have the callosal marginal up over here. And this supplies the medial area of the frontal lobe as it courses back, and supplies the very distal area here of the parietal area. Okay, and then down here, you have the posterior cerebral artery, which supplies the medial area of the temporal lobe, including the hippocampus, which is roughly right over there, courses posteriorly, and then supplies the occipital region over here. And this is the calcarine artery. So I think that to understand a little bit about cerebral vasculature and pathophysiology when it comes to disease, I thought I'd give you a case study. So this is a patient ST who, this goes back a number of years now, it's an older case, who's a 68-year-old right-handed business executive who had a 2.5-hour period with confusion as to time, birth date, and he was unable to appreciate correspondence relative to a recent trip. And this episode just lasted, as I said, 2.5 hours and didn't recur for another 7 years, where again, he was admitted to Columbia, where I was at the time. Let me just get my cursor back here. With an amnestic period beginning 8 days prior to admission with deficits in new learning and in long-term memory. He had mild amnestic anomia, and the magnetic resonance imaging, I'll talk about that in a second, showed a remarkably thin basilar artery and posterior sublunar arteries, although he had a normal EEG. So I saw him on a number of occasions, starting from 1995 to 1998. And this is from the old Wechsler memory scale at the time, where we have visual memory immediate, visual memory delayed, paragraph memory or logical memory immediate, and logical memory delayed. And I want to show you the dissociation between visual memory and verbal memory, where up here, visual memory is virtually intact both for immediate and delayed recall, whereas over time, his immediate paragraph memory sort of held fairly good, but you can see how his delayed paragraph memory declined over time. So by the time I saw him in 1998, he was around the 10th percentile, very different from his other memory levels of function. And so all we did functionally was put in a pacemaker, okay, in March of 1998, and gave him some nimodipine as well. And look what happened to his verbal memory. It almost went back to normal. It was an astounding recovery. And this guy, now 75 years old, worked for another 20 years. So what's the point of a case like this? And that is what we realized is that his deficit related to blood flow. It wasn't Alzheimer's disease. It had something to do with his posterior cerebral circulation that we were able to fix just by merely installing a pacemaker. So what's relevant about this is that it begins to make us understand something about the relationship between cerebral blood flow and function, and as it relates obviously to cognition. So if we take a look at cerebral hyperperfusion, I want to give you kind of a model of how decreased cerebral perfusion leads to injury in the brain. So under normal circumstances, the arterioles within the brain, that is the middle-sized blood vessels, expand and contract with changes in blood pressure. So when blood pressure gets a little higher, vessels contract. When blood pressure seems to go down, vessels expand. And we refer to that as autoregulation. Well, if we develop a condition where we're going to get decreased perfusion to the brain for whatever reason, it could be from a carotid artery disease, it could be from the heart, it could be from a number of different possibilities. What happens is that the vessels will expand, and at some point, if the CBF is declining, the vessels will become maximally dilated. And at that point, we refer to that as stage 1 hemodynamic failure. So the brain uniquely has a second backup system. What happens is that if perfusion continues to stay low, in order to maintain oxygen metabolism, the brain actually extracts more oxygen from the blood. So compared to almost any other organ in the body, the brain does not extract all the oxygen from the blood as a normal state of affairs. If you compare that to the heart, for example, when you have an occlusion in the LAD, you're going to expand the vessel through autoregulation. And then once that happens, the heart goes into ischemia and then to infarction. But the brain has a system of actually extracting more oxygen. And so it will continue to extracting more and more oxygen, assuming that blood flow is continuing to drop or is very low in order to maintain metabolism. But at some point, when all of the oxygen is extracted from the brain, we are now in stage 2 hemodynamic failure, and this is where metabolism begins to fall. And so there's a well-described cascade of events involved with mitochondria, the breakdown of electrical activity, the breakdown of the cell membranes, and this eventually causes worse and worse decline of physiologic function within the nucleus of these blood cells. Blood pressure is continued to drop, and at some point, infarction begins. And once a neuron or an astrocyte or some glial tissue becomes infarcted, that's it. You cannot bring it back. So when clot-busting drugs are delivered today during the course of an ischemic stroke, and I'll talk about that a little later on, this is the area they're really trying to target before infarction takes place. What area of ischemia can still be rescued? And that is really the goal of acute stroke therapy today. Again, once infarction takes place, then there's no recovery of that tissue, with the rare exception of an area like hippocampus, which does have some regeneration, but that is just a small area of the brain that has stem cells that can do that, but most of the brain does not. So let's talk about different kinds of stroke. You can classify broadly 2 kinds of stroke. There's our ischemic stroke and hemorrhagic stroke. Extreme ischemic stroke represents about 80% of the cases, and we can generally break them up into 4 areas of abnormality. There's large artery thrombosis. So if you take a carotid artery, for example, and you build up plaque and it builds up more and more and more, at some point you get a blockage in that vessel. You're getting poor perfusion distal to that point, and you could cause a stroke. The next kind of stroke I want to talk about is a cardioembolic stroke, and that is that a clot forms inside the heart and then travels up through the aorta and goes into the brain. And that can cause devastating syndromes. And this can come about from atrial fibrillation, it can come about from heart failure, but you're getting clots forming within the brain and going up to the brain. And then finally, you can have very, very small strokes where you have these in the most distal territories within the arterial system. They're referred to as lacunar infarctions. And it's a slightly different mechanism of infarction at these very, very small end arteries, but they can cause strokes. But we're not going to talk much about stroke recovery today, but the best prognosis after stroke are these small strokes from lacunar infarcts. Now we have hemorrhagic strokes. You can have intracerebral hemorrhage, or you could have subarachnoid hemorrhage. The most common cause of a subarachnoid hemorrhage is a ruptured aneurysm. We're not going to spend too much time today about that because the blood that comes about from subarachnoid hemorrhage doesn't penetrate the substance of parenchyma of the brain. It goes onto the surface of the brain and around blood vessels. I'll talk a little bit about that later on with regard to aneurysms, but most of the strokes that come about from hemorrhagic cause are intracerebral. And you can divide those into three. You can have those that are caused by hypertension, which is the most common. I'll go over here. You could have these large lobar hemorrhages, which can occur in almost any lobe of the brain. And then you could have very small microhemorrhages, which is a very different kind of pathophysiology, which I'll talk about a little bit later on, often associated with conditions like cerebral amyloid angiopathy. So let me show you a couple of different kinds of images that are typical and what a stroke looks like. So this is an old CT scan image where this is the left side of the brain, right side of the brain, anterior, posterior. When it comes to left and right, you have to realize that radiological space is different from real space. So the right side of the scan is the left side of the brain, and the left side of the scan is the right side of the brain. And here you have a stroke, ischemic stroke, located right over here where the arrow is pointing to. This is in the frontal lobe of the brain, and you could see this is noted by a hypodensity right over here. Okay. So the next kind of brain scan I want you to talk about, which is not as relevant to stroke, interestingly enough, is a T1 MRI, and I'm not going to go through the physics, but a T1 image in MRI is really the best for looking at anatomy. And so this is the anatomy of a somewhat normal brain here. You have the temporal lobes on each side. Remember, this is the left, this is right. This is the anterior, actually rather, this is the posterior portion of the brain, anterior portion of the brain, frontal lobe, occipital lobe in the medial area here. And again, this is really good for looking at anatomy. You do not pick up vascular disease as well with T1, with some exceptions. So, but this is really how we look at anatomy in particular cases. So if you want to really look at pathology, then you have to look at a T2 weighted image, which is the one here on the right. This is a stroke right over here, ischemic stroke, lower division, the left middle cerebral artery. Typically, this would produce a Wernicke's aphasia, left side of the brain, right side of the brain. And you'll notice that in a T2 image here, it looks bright. These are the ventricles here, and they also appear white as well on a T2 weighted image. This is an example of a T1 image of a stroke, and you see kind of a hole here. You really don't appreciate the pathology quite as well as you do a T2. So T2 is better for pathology. T1 is better for anatomy. This is a sagittal section, and this is an axial image right over here. So here we have a very large stroke. Now this is on the right side of the brain. This is a flare image, and the difference between a flare and a T2 is that on a flare image, the pathology comes out bright white, as does a T2, but the CSF remains black. So if you're going to look at lesions with a flare, this is really the best one to use it. So when do we use a flare image, and what is a DWI image? Well, a DWI image is diffusion weighted image. And what a diffusion weighted image does, it measures cytotoxic edema. That is the amount of fluid that is getting out of cells after a function occurs as part of the pathophysiology. And the diffusion weighted image picks that up and creates a white signal. Now, the thing about a DWI image, it is today the most sensitive way of picking up an acute stroke. And often within minutes of stroke onset, the DWI image will turn positive. It may not be quite as large as this at that point, but you'll get a change looking white. And so when a patient is brought into the emergency department and they give an MRI scan, they'll look at the DWI to see whether or not you have this acute area of infarction. A CT scan, when done acutely, often does not show a stroke because it takes time for the pathology as a CT measures it to become clinically apparent. And so when CTs came out, rather MRIs came out in the 80s and 90s, we began to realize that there was the ability to detect acute stroke, especially when they developed a diffusion weighted image. And so this is a FLAIR image of the same brain. And one of the things I want to show you is that you notice it looks negative here. There's a little bit of change here, but it's very difficult to detect. What a FLAIR image does that a DWI does not do is it allows you to look at chronic disease. So the DWI image often actually disappears in 2 to 3 weeks after the onset of a stroke. And that's when the FLAIR image appears, because the cytotoxic edema, which produces this lesion here, actually disappears. Doesn't mean the injury is gone, but the fluid that allows the DWI to detect it is gone. And so that's when you begin to look at a FLAIR. And the FLAIR is the best way of looking at chronic cerebral vascular disease. Okay, some other things to look at. So we were talking about the different kinds of strokes. Here we have an angiogram. This is a digital angiogram. As you can see here, this is the common carotid. This is the external carotid, which feeds the eye and parts of the face. This is the internal carotid, and right over here, you have your blockage, which forms a stenosis. And if you look carefully down here, it looks like a thread or a string. So they often refer to this as a string sign. And what that does, it causes perfusion failure distal to that point as it courses up into the brain. And here you have the lower division of the middle cerebral artery, and here's the candelabra of the upper division. So the strokes that are caused by this this blockage over here, is caused by the accumulation of plaque in the internal carotid, and that will then cause perfusion changes as we go distal to that point. So in contemporary neurovascular treatment, when a patient comes into the emergency department and they want to know, given that they appear to have a clinical stroke, how are they going to treat this patient? Well, the kind of state of the art right now is to, one, if patients come in within 4.5 hours, they'll inject a clot busting drug called RTPA, recombinant TPA, which counteracts the coagulation that's taking place and lyses or breaks up the clot. But what you need to do when patients come in is to see if there's a deficit that is reversible versus a deficit that's not. So if we take a look at this skin over here to the right, the green area refers to the total area of ischemia that's taking place within the brain. The red area is the area that's already gone to infarction. So the green area is still salvageable if you were able to get the clot out. The red area is not. Here in another slice, which is a little further down, you can see a larger area of infarction in the frontal lobe on the left side, but you see still a large area here. So we refer to this as a perfusion weighted deficit versus an infarction-based deficit. And when there is a big mismatch between the two, that tells the interventionist or the vascular neurologist that the green tissue is still worth saving. So at that point, they'll go ahead, give TPA, and then what they'll do is they'll actually, well, this is the TPA cascade. TPA is involved in the clotting cascade. And what you want to do is to block the formation of fibrin, because that is what creates clotting. And if you can inhibit the activation of fibrin, that's what breaks up the clot. So what the state of the art now is that once you've given TPA and you have that big mismatch between the perfusion deficit, that is ischemia, and the infarction, which is permanent, then you could actually go in with a catheter and literally pull out the clot with a clot retrieving device. And so here's an angiogram, and you can see here the internal carotid coming up. And right over here is an occlusion of the middle cerebral. And what they'll do is they bring the a catheter through here. They get the clot retractor out, and they can actually pull the clot out. And this is what the clot looks like when it's been, you take it out post thrombectomy. So thrombectomy is the name of the procedure. And so thrombectomy, when possible in large vessel disease, is the state of the art. And you can see that there has been recanalization of the vessel. It looks terrific here. This is a great outcome. And they will refer to this kind of outcome as a TICI, T-I-C-I, having to do with thrombectomy. And a TICI 3 is a perfect emergence of the full vascular flow. Another instrument that is often used in the setting of vascular disease is Doppler ultrasonography. And so this is color-coded Doppler. This is the common carotid artery. This is the internal carotid. This is the external carotid. So you can imagine the person is lying down with the body and the feet in this direction, the head sort of this direction, and this is the common here. And when you have a stenosis or an occlusion in the internal carotid, you can see it taking place right over here, which is denoted in blue. And this is also shows you the plaque denoted in blue. So that's another way that flow failure can be detected. It turns out that you can have probably up to 70 to 80% of a blockage in the internal carotid artery and still have fundamentally normal cognition. The brain's resilience in increasing oxygen extraction is so exquisite that even with that amount of blockade, you can still have normal brain function. But when you're above 80%, that's when flow failure begins to impact cognition. I wish I could talk more about that. It's just an area of interest of mine. So one of the things that I want to talk about a little bit in terms of anatomy, these are very old slides that J.P. Moore, and what I want to show you here is a small stroke that's right over here, which is right in Broca's area. And the reason why I want to show that to you is that I'd like you to understand that if you have a very small infarct right in the middle of Broca's area, that does not cause a Broca's aphasia, it causes an apraxia of speech. So with a large infarction in the upper division of the left middle cerebral artery, you're going to get a full Broca syndrome. But if you have a small branch occlusion just going to the inferior segment here of the left frontal lobe, it just causes an apraxia of speech. We didn't appreciate that till J.P. Moore discovered in 1977 with the CT scan that apraxia of speech is caused by this isolated lesion, and often patients have good outcomes. So in a Broca's aphasia with apraxia of speech, you can have apraxia of speech without a Broca's aphasia, but a Broca's aphasia always includes the apraxia as part of it because it includes the small area. So I'm going to show you, hopefully this works. Let's see. This is not good. This is not working. Let me see if I can get this to work. It would be a miracle if I did. Sorry, let me see if I can get this to. Let's see if I can get this off.
In this picture here. And just go ahead and do describe what as much as you can about what's happening there. Okay. Is there anything going wrong in the picture? Okay, so two things going wrong. How many people are in the picture? Okay. Can you use words if you can? How many people? Three people. Okay, good. Okay. And can you point to the mother? Can you point to the son? And is the son in danger of hurting himself? Okay. What does the sister want? Wants a cookie. Is that right? Okay. Now I'm going to have you repeat some things after me. I'm going to say something, you say it back to me. Today is Monday.
Today is Monday.
Okay. It is a sunny day outside.
It is a sunny day outside.
Okay, good. Now say, the spy fled to Greece.
The spy fled to Greece.
Okay, good. And say, the Chinese fan had a rare emerald. Come on, you're doing great, you guys.
Chinese fan, a rare emerald.
Okay, so the reason why I wanted to show this little clinical vignette is that to some neurology residents say, here we have a patient with a chronic Broca's aphasia. No, this is just apraxia of speech. Chronic apraxia of speech, because we don't have time now. His naming is normal, his comprehension is normal, and if you ask him to write, his writing is normal. So it's an isolated deficit related to his ability to articulate words. It's an articulation syndrome, not a language disorder. Just get back to what I had before. So I'm going to skip this next one. It was an example of Wernicke's aphasia, but you've all seen that before, so we don't have time to do that now. Let me just go back to the show. There we go. So. Serves me right for trying to put videos into something like this. So one of the things I want to tell you is that we can't always trust an image to make a cognitive or behavioral diagnosis. So here I have two different patients, and these are MRI scans, and you can see this is the lower division of the left middle cerebral artery, almost identical lesions. The difference, however, is that this patient had extensive white matter disease, and this patient does not. And what we have learned is that when you've lost these fiber connections from the white matter disease connecting the anterior to the posterior area of the brain, as well as between the two sides of the brain, the context of the lesion has as much to do with an outcome as the lesion itself. And so here I have three different levels of function. I have naming, comprehension, and repetition, which I have trifurcated into normal, mild to moderate impairment, and severe impairment, the acute stroke deficit, and 90 days later. And look at the tremendous difference. Although this lesion looks almost identical, this patient had a repetition disorder, conduction aphasia, and this patient had a severe Wernicke's aphasia. Never recovered. This patient did very well over time. So it shows you that the context of the lesion has as much to do with an outcome as the actual lesion itself. One of the things I also want to show you, this is from a paper that we published a number of years ago to remind individuals, and these are CAT scans, this is not an MRI, that you can have an aphasia both from a cortical and a subcortical lesion. And this is a thalamic infarct on the left. In this patient who we reported and gave a special description about. And the classic aphasia you get with thalamic aphasia is a transcortical sensory aphasia, which means you have poor comprehension, but otherwise fluent speech. And what differentiates the thalamic aphasia from the more cortical lesion is that patient is often hypophonic and may have a memory disorder as well. But so you can have a cortical as well as subcortical lesion that produces an aphasic disorder, and the image can show that. So I want to talk a little bit about deficits a little bit. So this is another patient with a lower division level left middle cerebral artery stroke, not the same one as before. And this patient has a stroke almost in the same territory, but this is a hemorrhage, okay? And this patient had a hemorrhage because of a abnormality in vasculature called the brain arteriovenous malformation. Okay. And these will produce very similar deficits in the acute period, whereas the ischemic stroke deficits will last a lot longer. But for patients with hemorrhagic stroke, it's surprising as the clot is absorbed into the brain. There still may be a deficit, but it's amazing how well patients actually can do. But you can tell at the time of acute presentation, you know, what the syndrome is ultimately like, because in the emergency room, before the image is done, these patients will look almost identical, but there is a variability that takes place whether this is blood or actually an ischemic lesion that's gone on to infarction. And this leads me to the notion that there is variability in both language and motor recovery during the acute stroke period, which usually lasts about 7 days. So this is the upper extremity Fugl-Meyer score. The Fugl-Meyer is a measure of disability of the upper extremity. And here we're talking about hand closure, moving of the arm, and so forth. And what I'd like to show you in a score that ranges between 0 and 66, how much variability there is over time. So if you look at patients here who are very disabled at the time of acute onset, just like those 2 scans I showed you before, look how much better patients did than others. Some patients barely recover, and some patients make actually rather good recoveries. Sorry, this wasn't supposed to go backwards like that. I have to move my picture over here. Here are patients with middle levels of abnormality. Some patients recover a little bit, some a lot more. And here are patients who had minor stroke deficits. Some make no recovery whatsoever, and others make excellent recovery. You can't tell at the time of acute stroke onset what's going to happen. These are patients here who had the Boston naming test. And what I did was I have to move this over here. Let me just, there we go. So what I did was I truncated this from 0 to 15 from the total score of 60 on the Boston naming test. And you could see that some patients would make no recovery at all. This patient was fairly aphasic, made no recovery. Here, this patient in the box started out with a fairly strong anomic syndrome and got much better over time. Here's a comprehension, similar set of patients. Some patients recover very well, and some patients no recovery at all. The point is that the first time you see a patient, I don't care how big the lesion is, you cannot predict the outcome on the basis of an acute stroke syndrome, what they're going to be like on discharge. And this is something that we have to keep in mind. So that giving patients counseling on day 2 of stroke onset doesn't necessarily correspond with what you can see on day 7. Okay, here's a patient whose data I published in a chapter of a book. This is a very large left middle cerebral artery infarction. Had severe, when the patient was acute, I remember admitted to NYU before coming to Columbia. This patient was a global aphasic. And I saw the patient 2 to 3 years later, and it was absolutely extraordinary. The patient was just left with an apraxia of speech and an anomia comprehension was normal. You never would have guessed it. And so again, the acute stroke syndrome doesn't necessarily tell you, looking at an image with this profound deficit, what the patient was like over time. So I just have a few minutes left, and we just want to go over a couple of small syndromes. This is an arteriovenous malformation. What this is an abnormal connection between an artery and a vein. It doesn't have the usual capillary bed, but rather a direct connection between the arterial system and the venous system. And the risk for this kind of abnormality is cerebral hemorrhage, because these are very weak intramedullary blood vessels. There's no brain here. This is all blood vessels. So you have this mass in the middle of the brain. This is what an AVM looks like. This is a temporal lobe Abm here, as you see on an MRI scan. What's really interesting is that this patient came to clinical attention because of a seizure, not because they had a language deficit. And most patients with an AVM, if they haven't had a seizure or they haven't had an intracerebral hemorrhage, which is the great risk here, a number of these AVMs will be discovered incidentally by accident looking for something else. This is what an AVM looks like on the same patient on an angiogram. This is the internal carotid going up. This is a feeding arterial vessel, and this is the cluster of abnormal vessels between the artery and the vein. This is what an AVM looks like on a three-dimensional angiogram. This is the feeding artery going into the AVM, entangled mass of blood vessels. And this is the draining vein. Look how engorged this is. And that's because the arterial supply of this goes into usually our veins, and then goes into a tissue, then comes out of the tissue in a series of capillaries, goes into venules and veins. And so this acts almost like a resistor, and it tamps down the pressure coming from here. But if there is no way to block the pressure because of the arterial system not going into capillaries, it puts too much pressure on the vein, and that causes an AVM. These are cerebral aneurysms that should show you that. This is a saccular variant aneurysm. This is the basal artery here. This is the anterior, this is the posterior cerebral going from here. This is the posterior communicating artery on both sides. When this aneurysm ruptures, it causes a devastating syndrome. This is a fusiform aneurysm here. And so what it is that the aneurysm actually encompasses the blood vessels of the wall. So the blood flows through here, goes to this vessel, goes to this vessel over here. These are very difficult to treat. These are often treated either by putting a clip around the base of the aneurysm, or you can actually put coils inside the aneurysm, and that can cause thrombosis of the aneurysm by itself. Two common ways of treating saccular aneurysms. This is an aneurysm here. This is the subarachnoid hemorrhage caused by a rupture of this aneurysm. And the reason why I pointed out is that the anterior communicating artery syndrome is the one that often produces the most severe kind of amnestic syndrome from an aneurysmal rupture from an aneurysm. This is another example of carotid artery stenosis. This is that string sign I was telling you about before. This is another example of that. Again, this is caused by the formation of a stenosis here from the buildup of plaque within the cerebral artery. The two ways of treating arterial stenosis like this, carotid artery stenosis, you can actually take out the clot through a process we call a carotid endarterectomy, or you can actually put a stent and actually do angioplasty, which actually takes the tissue and compresses it against the wall, and then you put a metallic stent, as you can see over here, and that also produces the ability of the blood to be reperfused to the brain. The TCAR refers to just the technique of delivering that catheter. Finally, I wanted to point out with carotid artery disease, when you have carotid artery disease, what you're doing is the clots that are formed from that, not the clots, but the perfusion failure produces ischemia in the most distal territories between adjacent cerebral arteries. So this is known as a watershed infarct. This is the anterior, this is the anterior posterior artery. This is the middle cerebral artery. And so at the most distal portions of the vessels where you're going to get the infarction. You also get infarction in the territory between the ACA and the MCA here, and the PCA and the MCA here. And this is the infarction you get from water zone infarction from carotid artery disease. You get something like this. This is how you get the transcortical aphasias. And this is what it looks like in an MR scan. I just want to show you that this is watershed infarction from a large stenosis in the right middle cerebral artery, well, rather the right carotid artery. I do want to make the distinction here between the white matter disease you see from hypertension. It is different. And finally, these little Swiss cheese looking holes are microhemorrhages coming about from cerebral amyloid angiography. The two kinds of images that are most commonly used to measure hemorrhage are either susceptibility weighted imaging or SWI or gradient echo. And this is an SWI showing the presence of this, all these little small hemorrhages here, which is associated with cerebral amyloid angiopathy. So I think that is about as much as I had time to present. I'm going to unshare my slides. And I'd like to open the floor for any questions that you might have.
Thank you so much for this amazing lecture. I think our viewers are definitely going to learn a lot from it. We do have a few questions. So I'm just going to go ahead and start with the first one. So one of them is a question that we've been getting across the different neuroanatomy lectures. And this one is regarding studying for neuroanatomy. Do you have any books or applications or anything that our students could use to study for neuroanatomy specifically?
Well, there is a very old program text in neuroanatomy called the Program Text in Neuroanatomy. It was published in the 1960s by Sidman and Sidman. It's a great way of learning neuroanatomy. And one of the Sidmans was a psychologist, an early neuropsychologist back in the 50s and 60s. And his brother, Richard Sidman, was a neuropathologist. And so the textbook of neuroanatomy is really a great program text. Sidman and Sidman, it's an old book, but it's a fantastic teaching tool.
Perfect. We'll make sure that we add this to the resources. So here's a question in our Q&A chat. What was cerebrovascular anatomy first discovered by imaging or postmortem studies? If it was imaging, which technique was used? And how much anatomical detail can you get from your imaging techniques? So this is a three-part question. So I guess first question is in terms of if this was the first discovery of cerebrovascular anatomy, if it was imaging or postmortem studies.
Well, postmortem obviously was the original one, and Berzelius did that a long time ago, and so that goes back hundreds of years. In terms of imaging, there was a technique called neuroencephalography, which actually was one of the imaging techniques, very uncomfortable for patients, where they actually injected air into the cerebral spinal column, and that was pretty tough. So CT imaging was discovered in the 1960s, and that was the game changer. And we saw anatomy there we never saw before. That was before my time. And then MRI came out in the early 1980s. And when I first saw my first MRI scans, I thought I was looking at neuroanatomy slides. I was looking actually at actual slices. That's how good it was. The original was 0.5 T. With T referring to Tesla means the degree, the size of the magnet used to measure it. And it's gone from 0.5 T to 1.5 T. 3 T is the most common clinic imager. And now they have 7.5 and up to 90 images where you can actually see the gray matter, white matter junctions. And it actually looks like you're looking at it under a microscope. So the more power we have, the greater the resolution of what you're going to see. When the first CTs came out, we saw a lot of white spots, hyperintensities. And people said, oh my God, the prevalence of multiple sclerosis is just unbelievable. You didn't realize. And it turned out to be not MS at all, but white matter disease. Yeah. So, so we see things we don't even completely understand as we get into greater and greater resolution. But that's sort of the history of imaging right now. But right now, 3 Tesla is the standard of care for most imaging using MRI.
Okay, perfect. I think that your answer pretty much kind of tap into the different question this viewer had. And then in terms of the 7T, I know that it's being used for research now more than anything. Do you see the field moving forward in terms of introducing 7T clinically, or do we, in terms of patient care, is a 3T pretty much enough?
Well, it depends on what you're looking for and what those high resolutions tell us. Right now, for example, imaging, MRI is not very good for Alzheimer's disease. That's an example. And, they're using, amyloid PET and tau PET for looking at it from a more, looking at it from the point of view of detecting proteins. But it may be that as you go into higher resolution, you're going to be able to take a look at the blood-brain barrier more carefully. And that may be more suggestive of what is happening with Alzheimer's disease, since it's believed that, you're having a breakdown of the blood-brain barrier, and that's allowing beta amyloid to permeate into the parenchyma of the brain. So it all depends on how we're going to end up using it, and what kind of maybe there's going to be an amyloid MRI someday. Mm-hmm. We don't know yet. So it all depends on how clever people are over time using technology.
Yeah, it is an exciting time, nevertheless, with all these new imaging techniques coming in. So we have another question, and it goes, how long does it typically take for a given brain region to progress from autoregulation to ischemic or infarction in a patient? This person was curious to know whether it's more of a gradual versus an abrupt process.
So it takes time for it to take place. It depends on the size of the stroke that's taking place, and how large the clot is. But I had a case a number of years ago where we were trying to embolize, that is, put a coil into a fusiform aneurysm that was in the angular artery, which of course feeds the superior temporal lobe. And unfortunately, there was an adverse event there. And from the time that the event took place on the table on the angiogram to the development of the aphasia was exactly 4 hours. And so that was the first chronology I ever saw in a human model, how long it takes. Yeah. So, but with a larger lesion, it could happen faster.
Faster than that, okay. I do have, I see we're almost about the hour, but I do have one particular question. Sometimes when you have a patient that had a stroke and they're put in a statin and they're concerned about bleeding, do you have any recommendations on how to explain, the pros and cons as to why you're put in a medication to prevent a further stroke, but there's also that side effect of bleeding, and it seems to increase the patient's anxiety over the recovery process?
Well, that's a great question. And this is a risk-benefit analysis. So when they did the original TPA studies, which were published in the New England Journal, I think it was 1995, what they showed that there is increased risk the longer you wait to give the TPA. And at 3 hours, there was a crossover in the risk between the threat of hemorrhage and the beneficial effects of reducing the infarct size. And so the general rule of thumb is time is brain, and the faster you can get TPA in, the less likely you're going to have an hemorrhagic event. Now, you can also have the instance where you can have a hemorrhage a day or two later after that acute event. And what happens is that when you have the stroke and you have the ischemia, not only do you create ischemic brain, you also get ischemia to the blood vessel itself. And so the blood vessel breaks down and you have what you know as secondary hemorrhagic conversion. And so what was originally looked at just as an ischemic stroke, as you see it on the scan, all of a sudden there's a hemorrhage that appears on the next scan when you do later on, because some patients seem to get a little worse. Why is that? And you can see that there was hemorrhagic conversion of the original stroke. It doesn't happen all the time. It depends on the place of the stroke and how much of the vessel was ischemic. But in terms of the upfront effects, it really has to do with the cost benefit of how quickly you can get in and out. It also depends on the tortuosity of the vessel. So if you're going to do thrombectomy, you're going to put the clot retractor in. You know, how difficult it is to get the retractor into that space. Are you going to break a blood vessel? That can happen. And so those are all risks. But if you have a really large vessel occlusion, and the risk is a hollow hemispheric aphasia and hemiparesis and hemisensory loss, that could be devastating for the rest of one's life. Sometimes it's worth that risk for the amount of blood that may be may happen there. In the beginning, you know, there were more deaths and more adverse events, but now it's becoming much more routine to have a fairly good outcome.
Yeah, so it sounds like giving good counseling to the patient and their family regarding these risks and benefits.
That's right. So that's why they look at something like, I didn't talk about the anti-stroke scale score, but if the anti-stroke scale score is below 5, which is a relatively minor event, they're much less likely to do clot retraction unless the patient has a very dense wernicke's aphasia. But if you're at 18, 19, and 20, then they're going to take the risk because you're going to be left with a devastating syndrome.
Yeah. All right, well, thank you so much. This was an extremely useful lecture. I know many of us are probably going to go back to listen to this recording. And for those who are watching, we just want to quickly, I'm going to go ahead and share my screen because we want to introduce our next series. So we will be we're starting our next series. One second. Let me I lost my screen. Okay. All right, here we go. So, yes, we'll be starting our fall series on September 13th with Dr. Jennifer Manley, who will be presenting on population neuropsychology, community center brain health research at 5 p.m. Eastern time. So make sure you sign up to get our emails regarding our next series. And thank you everyone for watching our first No Neuroanatomy series this summer.